I got the signal. I got the little thumb up start here. Hey, great to see everybody. Welcome to the session on Justice Involved in Medi-Cal. I'm John Friedman on the ITUP board, and I'm also with a company called Health Management Associates, which is an independent consulting firm in the safety net space. And this session is going to be, to me, and hopefully to you, a really exciting space that we are entering in California related to justice involved. I wrote a paper actually in Health Affairs about 10 years ago about the challenges that the ACA, the challenges and the opportunities that the ACA brings with the justice involved population. Both the opportunities for what the coverage expansion means and the challenges associated with people who have experience in the justice system as inmates and also the structures involved in the justice system. So one of the things that Mark Galley could have spent his entire presentation on was the breakthrough that California had in what's known as the Justice Involved Initiative here. It's a light year type of step that California has been able to negotiate with the federal government to bring Medicaid funds, Medi-Cal dollars, directly into the justice space. This is a huge breakthrough. And there's a handful of other states that are following California in this new initiative. It brings, at its fullest extent, there's eligibility dimensions to this, there's financing, there's new programming, and there's community handoffs involved in this justice initiative. It brings Medi-Cal dollars into what are known as the four walls, which previously had been prohibited in the Medicaid program. So this is a huge breakthrough, and as I mentioned, Mark Galley could have spent in his entire remarks talking about that, but then that would have obviated this session. And here you're going to get a presentation from colleagues and practitioners who are actually implementing this program here. Just in terms of the order of the session, we're going to have Cindy Armendariz from DHCS. She's going to give us some level setting about what this initiative is. It has lots of tentacles, lots of pieces. And those of you who are working in calaim know that calaim is not one thing, right? You have to explain it's not one thing, it's like 50 things, and then those 50 things subdivide into another 50 things, and so forth. So it's very hard sometimes for us to get oriented. What are we talking about? What, where? So Sydney's going to level set for us. And then Lynn and Tanya from San Diego and from San Francisco, large jurisdictions, large justice systems are going to give us their perspectives of the implementation challenges and opportunities that are going on in the localities. And then I'm going to ask some questions, and then you get to ask some questions here. So at this juncture, I'd like to turn it over to Sydney.
Thank you, John. So good morning, everyone. My name is Cindy Armendariz, like John said. I am the chief of the Justice Involved Reentry Services branch at the Department of Healthcare Services. So my seat is really hot right now because I feel like all of you are probably mostly interested in hearing about DHCS's calaim JIs. So I'm happy to be here with all of you today. So I'll just give a brief overview of calaim JI. What is it? What are we doing? What does it cover? And things like that today. So first, I'll start off with the demonstration rationale and the goals. So how did we get here, and where do we want to go? So up until now, most of you might have been familiar with the federal Medicaid law known as the inmate exclusion, where inpatient hospital care was the only service that could be covered by Medicaid for an individual considered an inmate of a public institution. In 2018, Congress passed the SUPPORT Act, which required Health and Human Services to provide guidance to states to seek 1115 demonstration authority to waive this inmate exclusion, which would then improve care transitions into the community for incarcerated individuals. Before Health and Human Services released their guidance, California, along with 14 other states, submitted an 1115 demonstration request to provide pre-release services to justice-involved populations. So California was the first state in the nation to receive approval to authorize federal Medicaid matching funding for a select set of Medicaid services for eligible justice-involved individuals in the 90-day period prior to their release from incarceration in prisons, county jails, and youth correctional facilities. Since then, 2 other states have also received federal approval. I believe it is Washington, and I forget the other one, but I know for sure Washington received approval in July of 2023 as well. So what are the goals of the Justice Involved Initiative? So there are 3 main goals to the work that we are trying to do. So the first is, of course, advance health equity, which I think Dr. Gailey presented earlier in the morning of that first guiding principle for Health and Human Services Agency is a focus on equity. So we, of course, are mirroring that guiding principle. I think we are probably all aware that the issue of poor health outcomes, and death for incarcerated people is a health equity issue because people of color are often more incarcerated than their counterparts, especially for offenses tied to mental health and substance use disorder related offenses. These individuals can have considerable healthcare needs but are often left without care and medications upon their release. The second goal is to improve health outcomes. So we hope that by providing a targeted set of pre-release services in the 90 days before the person is released will help establish a supportive community reentry process, which will then help connect the individual to physical and behavioral health services upon their release, which will then ultimately improve their health outcomes. And lastly, we're California. We always like to be the first. We always like to be the model. So we had to throw that one in there. We hope to serve as a model for the rest of the nation. Since we were the first state to receive approval, we hope that through this initiative we can, of course, encourage our other states to follow suit and provide similar services to their justice-involved populations. So again, we love our puzzle pieces. I think you saw Dr. Gailey's puzzle piece. We're doing it too. So the calaim Justice Involved Initiative is comprised of several components. So as you can see on this slide, the first kind of puzzle piece to this initiative is the pre-release Medi-Cal application process. So that went live for county social services departments January 1st of 2023, where they are now required to provide Medi-Cal applications to people who are incarcerated and help enroll them in Medi-Cal prior to their release. The second puzzle piece, which is probably the biggest and most complex, is the 90-day services. So that's the 1115 waiver, which provides the targeted set of Medi-Cal services to individuals in the 90-day period prior to their release. The third puzzle piece is the behavioral health link, so making sure that the person, if they do need behavioral health services, that they have a direct link to a behavioral health provider prior to their release into the community, and then can continue those services upon their release. Next, we have Enhanced Care Management, our ECM benefit through Medi-Cal, which went live January 1st of this year, where people who qualify for the 90-day services pre-release will then qualify to receive Enhanced Care Management services through the JI population of focus through our Medi-Cal managed care plans. And then that leads into the last two puzzle pieces, which are really heavily focused on community supports and justice reentry and transition providers. So leveraging the lived experience and expertise of our community-based organizations to help provide supportive services to justice-involved individuals once they're released into the community. So now we'll get into a little bit of the nuts and bolts of the Justice Involved Initiative. So I'll talk about the eligibility criteria, what services are covered, and then I'll also do a plug about our PATH funding as well. So here's the timeline. So like I mentioned, January 1st of 2023, we started with the pre-release Medi-Cal application mandate that required all counties to facilitate enrollment in Medi-Cal for incarcerated individuals. Next, January 1st of this year, the enhanced care management for the JI population of focus went live. Again, that's a special Medi-Cal managed care plan benefit that provides a more robust set of Medi-Cal services to qualifying individuals. Then lastly, again, this is kind of the biggest chunk, from October 1st, 2024 until September 30th, 2026, we have a 2-year period for correctional facilities to go live with pre-release services. So correctional facilities will have a 6-month readiness assessment review process, review and approval process before their go live date. So again, that's that biggest chunk of time where the correctional facilities can start going live with their pre-release services. So the eligible correctional facilities that are required to provide Medi-Cal services in the 90-day period before an individual is released, we cover state prisons, county jails, county detention centers, county detention facilities, and county youth correctional facilities. And it's important to note that pre-release services will only be provided to individuals prior to leaving a correctional facility and re-entering the community. So the 90-day pre-release services do not include state forensic mental health hospitals like those that are ran by the Department of State Hospitals. It does not cover city jails or federal prisons. Those 3 entity types were not included as part of our CMS waiver approval. So now I know this slide has a lot of words. It's a little busy, but that just goes to show the eligibility criteria for pre-release services. So there's 2 main criteria for adults to qualify for pre-release Medi-Cal services. So that's there on the left-hand side, I believe, in the yellow box. So they need to be a part of a Medicaid or CHIP eligibility group. So those groups are reflected in the blue box on the right. And they also need to meet one of the following healthcare need criteria. So they need to have a diagnosed mental illness, a substance use disorder, chronic or significant clinical condition, an intellectual or developmental disability, a traumatic brain injury, HIV or AIDS, or are pregnant or postpartum. So those are the 2 main eligibility criteria for adults. One important thing to note is that all Medi-Cal or CHIP eligible youth who are incarcerated in a youth correctional facility qualify. They do not need to meet one of those healthcare need criteria. And the age is not a factor in the youth criteria. So if someone, let's say, is 22 and they're incarcerated in a youth facility, we count them as a youth, so they would be eligible to receive pre-release services. And so this slide just pretty much covers the covered pre-release services through this initiative. So we cover things like reentry case management services, physical and behavioral health clinical consultation services, laboratory and radiology services, medication and medication administration, medication-assisted treatment or medications for addiction treatment, also known as MAT, and services that are provided by community health workers with lived experience. And then in addition to those services, we also cover outpatient prescribed medications and over-the-counter drugs, and also durable medical equipment upon the person's release. So that was a very, very high-level overview of calaim JI, and I also did want to plug our PATH funding as well. We did receive $410 million in PATH capacity building funding to give out to eligible correctional facilities and county behavioral health agencies to stand up these processes. We definitely understand this is not a simple thing to implement, so think of it as, kind of startup funding for these entities to be able to create processes, build their IT infrastructures, their billing systems, and things like that to provide these services. So funding is still available. If you or if you know someone that has not applied for funding for their agency, please reach out to us. This is free money essentially to help the counties start up these services. So I'm happy to take questions. I think right now, or no, at the end. Sorry, don't listen to me. At the end. But also, please take down my team's contact information. This email address on the slide is a direct contact to my team and I. We manage the inbox. It will not go into a black hole. It goes straight to one of my analysts. So please feel free to reach out to us as well. Thank you.
Thanks so much. Thanks so much, Sydney, for that presentation and level setting. You know, this is really an interface of massive systems. The Medi-Cal program, just as a little perspective, California's Medi-Cal program is larger than the next 3 states combined. Okay, that's how big our Medi-Cal program is, touching a quarter of the state's population, 40 million people in the state. And we have this justice system here, the state prison system, local facilities, and one of the big differences between the state prison system and the localities is that the population in the prison system is relatively stable and moves more slowly. And jails are chaotic here. They have lots of things they have to manage, inflow, outflow, get me to the court date at tomorrow, et cetera. And so we're going to hear from people on the ground. Here, our next panelists, Lynn and Tanya, to share their implementation approaches in San Diego and San Francisco. Lynn?
Thank you. Hi, I'm Lynn Carr. Is this working here? Oh, let me turn this on here. Good afternoon. I'm Lynn Carr, Chief of Agency Operations with the County of San Diego. I work for a department called Medical Care Services, and we're really fortunate in San Diego that we have a team that's called SDAIM, San Diego Advancing and Innovating Medi-Cal. So we're probably one of the only counties that actually at the very start of calaim designated staff to support the implementation. And so when the JI initiative came about, it was really exciting because in my prior role, I came from our Office of Homeless Solutions, creating programs to stop the cycle of homelessness and incarceration. So this was almost a natural fit to take on this and help support our justice partners and our behavioral health services and our social services department. So we at the SDAIM team, we act as the facilitators, the project managers. How we've approached the JI initiative is really finding out, working closely with our sheriff's department, our probation department, our social service department, our behavioral health services, to identify who are the right people, who are the contact, who are the best contacts, who are the boots on the ground, as well as the decision makers, and then bring everyone together. So what we did, Sydney did a great overview of the timeline and the different components. The first mandate was the pre-release Medi-Cal enrollment, and that started January 1st, 2023. And so we started in June of 2022 bringing together work groups. So of course we used our SDAIM, Justice Involved Work Group. We brought together our county stakeholders and we began meeting. We then brought on, shortly after that, we brought on HMA as our consultant. That has been incredibly helpful to be a neutral party, bringing together our justice partners, our health and human services partners, meeting on actually a weekly basis as we map out the current process and the future processes. And now lately, just recently, we brought in our managed care plans, as well as CDCR, our sheriff's department, our probation department, and HHSA. So I would say I can go into more of the weeds of how we're implementing, but I wanted to just start off by saying it's been so important to bring the right people to the table. This is, I think Orange County said this in a recent meeting, it's not an initiative, it's a movement. It really is changing the way we're doing business. It's not something that happens overnight. We're really, the amount of people, just to frame San Diego a little bit, is we have approximately 4,000 people on any given day in one of our 7 jails. We have about 250 youth in one of our 3 youth facilities. That's not even including the number of people coming back to San Diego from prisons. So it's in about let's say 1/3 of our population has a release date. So 2/3 don't have release dates. So it is chaotic and there's a lot of moving pieces. So we're just bringing the right people to the table as we start planning the implementation. So I'll turn it over and we can, I think, get more into the weeds.
Yeah, good morning or good afternoon, everyone. So I'm Tanya Mara. I'm social work background. I have been working within the jail setting for the basically my entire career, almost 20 years now. I'm currently the Deputy Director for Jail Health, and the Director for the Jail Behavioral Health and Reentry Programs. And we are an integrated part of the San Francisco Department of Public Health. We are one of the few counties in the state where the healthcare is provided by a Department of Public Health organization, and we are an integrated member of the San Francisco Health Network. So I highlight that because it really is a game changer in terms of how we provide care in our jail, and also in terms of how the implementation of the Justice Involved initiatives for calaim, how that's being implemented and the ease at which comparatively it's being implemented. So just quick level set, how many of you know the difference between a jail and prison? Okay, so most of you do. So jail, pre-adjudicated, the vast majority of people in jail, everyone that gets arrested goes to jail. Most people haven't been convicted of a crime. So in San Francisco, 96% of our population has not been convicted of the crime for which they are in custody. In prison, everyone is adjudicated. They've all been found guilty of a crime and been sentenced to time. So the population's very different. And I just want to highlight that I am going to be speaking from the jail perspective primarily today, not from the prison perspective. The calaim legislation was very much written to slot in nicely to prisons, where for the most part, release dates, there's, you know when it's 90 days prior to release. And it's much more controlled and organized in that manner, in that regard. Jails, as John mentioned, is profoundly unpredictable. 50% of our population is gone in 3 days or less, 76% gone 7 days or less. So it's quick. And then we have some people that are in jail as long as 11 years. So the span of time people are with us is so profoundly variable. And it forces jails to provide care in two ways, really. So it's like quick, urgent care, crisis intervention, acute stabilization. Well, not really acute, but stabilization. And then there's like long care, illness management, right? Management of diabetes, hypertension, mental illness. And so it's really this like very different responses. So having come from the jail, let me just say that what you all are experts in, insurance, is something I never thought I had to deal with. I was like, what is this Medi-Cal thing? And why does my autocorrect keep getting it wrong? And does it have a hyphen, or is there not a hyphen? And is C, A, and L all capitalized, or just a C? Like, I really thought those were questions I'd never have to answer. But alas, here I am. Surprise, surprise. So what I will say, in San Francisco, we're fortunate in that when the Affordable Care Act was implemented, we had a very progressive and innovative sheriff, Ross Mercarimi. I have to always mention him because he took it upon himself, when our Department of Public Health did not, to begin an insurance enrollment program in our jail. So while the ACA didn't allow for people to have Medi-Cal and while they're incarcerated, and didn't allow billing, it allowed enrollment. And that is something we started 8 or 9 years ago. And that is huge. And what it did was establish relationships and workflows with our county social services department. And so that really, I think, speaks to the fact that we, in many ways, were able to get ahead of the game. And a lot of the things that are required through the calaim legislation are absolutely transformative. And what I will say about DHCS is, like, I think, the criminal justice system is new to them. And this has been a learning opportunity for them. But the humility with which they have approached this has really been remarkable. And I think all your analysts probably know me on a first-name basis because I email that email address all the time with questions. And they've been really great partners. And so I just want to acknowledge that. What the challenge is for us in San Francisco is scale. So a lot of these programs we're very fortunate we have. I worked as a consultant and did evaluations of jail throughout the state. What we have in San Francisco is unusual, and so we're very fortunate. What is going to be a challenge for us is scaling it up. And I know there was another discussion earlier about workforce. Workforce is a huge barrier. So Anyway, I will leave it at that. And if anyone can tell me how to properly spell Medi-Cal, you can let me know after, because I'm still not sure.
Let me ask some questions. So, uh, is there just an easy file transfer between the jail inmate roster and the eligibility system? That's easy, right? It's just a file match, right? What actually goes on in making that happen?
Yeah, so we use an electronic health record called Epic, which probably many of you are familiar with. I know our colleagues in Santa Clara and San Mateo use that as well for their jail and their community healthcare system. And what's great is our Department of Public Health across the board is implementing Epic. So I can see the hospital records, primary care, all of our clinics, and County Behavioral Health is actually transitioning to Epic right now from Avatar. So anyway, when we actually only implemented Epic in the jail in 2021, and there's an automatic file transfer process that happens between the jail and Epic when someone's booked into the jail. So without getting into the technicalities, which actually I couldn't even get into if I wanted to, so don't ask, there's some sort of electronic file transfer where the information from the Sheriff's Department is uploaded into Epic. It opens the patient encounter. So Epic, because it's what we use in the hospital, has a real-time eligibility process. It's through Experian, and it automatically runs patients' insurance. The biggest problem with it is it's not really accurate. So what we do is we, yeah, sorry. I don't know. I didn't like, I'm used to that happening, being like, oh, it's not accurate. You guys seem surprised. That's like standard operating procedure in the criminal justice system. You have to come at everything with suspicion. But anyway, so then we have someone actually manually looking up every patient, and so checking a lot of other sources of information. And so then that information is put in Epic. So, current state, it's manual. We're entering information in Epic, and we have a spreadsheet because, we'll never get rid of Excel, no matter how tech savvy we ever aspire to be. But there is some sort of electronic interface. So
Tanya, you're kind of at one end of the spectrum of interface, and maybe Sydney or Lynn, you could chime in about what are the other pieces that are maybe not so electrified that have to come together here.
San Diego County looks very different. We were talking about the differences is your Health and Human Service Agency, right? Runs your public health, runs your jail health. That's not how San Diego is. So our Sheriff's Department has a vendor, a contractor that runs our jail health. So our process looks very, very different. What happens is, I'll kind of go through the pre-release Medi-Cal enrollment process because you'll see how manual it is. But someone goes in, we're now, because of the mandate, we are screening. I'll go back and I'm going to give us credit. About 10 years ago, we also implemented an enrollment process. So San Diego is one of those counties. Very lucky. We were one of the first counties that started enrolling people in Medi-Cal. However, only people with a release date, and I don't know if that's the same for San Francisco. Yeah. So it was really 1/3 of our population we were enrolling with release dates. This is changing that because it's everybody. So as someone comes in, they are screened at intake. Do you have Medi-Cal? If not, would you like to enroll? And so that's one point, and then that's a manual point, right? We're keeping track of those that say, no, I don't, and I would like to enroll. And then we have vendors, we have CBOs that go, community-based organizations that go into our jails. They assist people with enrolling in Medi-Cal. And then it is another manual process of then sending those completed applications over to our social service department, who then does that process of eligibility. And then another manual process as someone would then on release date get turned on. We did not have an interface. We didn't have a signed data use agreement of sharing that data between our social service department and our sheriff's department. We now have a data use agreement, and we're automating the process. But I mentioned before, we have 4,000 people any given day in jail. So it's an Excel sheet right now that's going between our social service department into our jail of booking and release dates. It's very manual. We're working on automating it, but our CalSAWS does not talk to our jail information management system. So that's another process we're working on.
So these are 100+ years of development of the jail system, and almost 60 years of development of the Medi-Cal program, and never having to interface here. That's what the front line of this work is. What happens if I'm released at the court there? Because release doesn't occur through a single door in a jail. I could be at a court appearance, brought there by the custody division, and the judge says, "You're free to go, Mr. Friedman." What happens?
Right, so then someone would manually have to update our social service department that they were released that day. Then someone would need to go in and enter a release date so that Medi-Cal could be activated. So right now, very, very manual.
Do you want to speak?
Yes. So I told you my seat was really hot, right? No, I think in response to the concerns about the manual process, DHCS, we are building a screening portal for this initiative so that we can help the counties automate a lot of these screening processes and enter in the eligibility criteria, enter in the release dates, and that the county social services department, the correctional facility will both have access to it, so that the hope is to reduce a lot of that manual labor. I can't speak to the Medi-Cal name. I think that was just a California thing. We had to be different, but hopefully,
always.
But hopefully, the screening portal that's coming, hopefully this fall by the October 1st go live date can help to automate a lot of those eligibility and screening processes.
Next question for the panel that I have is, you talked about the eligibility pieces of this and the wiring and asking, what do you foresee as the care transformation that's going to happen around how care is provided in the jails? Anybody want to take that on?
Sure. I mean, it's going to be a game changer. So the vast majority, as mentioned earlier, of jails have healthcare provided by for-profit contractors, which to me, for-profit and healthcare shouldn't go in the same sentence, but I won't, this isn't really a jail population, or jail, I'm not talking to sheriff's department people, so it's safe here. But that can be a controversial statement. So, when you have the luxury of being a part of the Department of Public Health, you provide all the care that patient needs, and you don't care how much that costs, right? I mean, you care, but not. You don't really, it doesn't drive your decision making. So we're very fortunate in that we provide, medication assisted treatment. We bring contractors in to do methadone. We have specialty care through UCSF at San Francisco General. I mean, we provide excellent health care and we have very robust services. Like, could we be better? Absolutely. Are we perfect? No. But we are very fortunate. When you are working within a budget and you report to the sheriff's department, it's a different story. And so from that regard, so let me just step back really quickly. As someone that's worked in the criminal justice system for 20 years, to be effective as a healthcare provider in a jail system, you have got to be the expert on every other system that interacts with your patient. You've got to, I'm a social worker, but I have to really understand what the doctors are talking about, because I don't like to not know I seem like I don't know what I'm talking about. I'm like Google PhD. But you have to understand the courts. You have to understand criminal law. I literally had an email from an attorney this morning asking me for mental health law advice. I was like, you should not be doing this. You have to be an expert in how the sheriff's department operates. You have to be an expert in how probation operates. And you have to be on really good terms with everyone. Because to make things work for your client, you have to try to be the one in the middle making all those systems that don't talk to each other, that don't share information, work together so that your client has a good outcome at the end of the day. And it is extremely challenging, extremely resource intensive, and by the end of the day, sometimes you just want to barf because you've had to try to get so many people to do what you want, and it's exhausting. So in that regard, what the state is doing is huge. They're basically saying, criminal justice system, You no longer get to just like do your thing and everyone else has to step into line. They are saying you've got to provide this high standard of care. That is a game changer. There are jails that don't do any medication assisted treatment. There are jails that don't have contracts with county hospitals. So people meeting acute psychiatric criteria sit in a cell and don't go to the hospital. There are jails that don't do long acting injection psych meds. There are huge disparities in the healthcare provided in jails throughout our state, throughout the country. That needs to come to an end. That is unacceptable. And what the state has done is said, we have a population that's in jail right now. This is an opportunity to get this population healthy and well. Okay, not ideal, a jail, I get it, but let's like be in the real world. They're here, we don't have control over that, the courts do. And let's get those people as healthy as they can be. Let's give them the best care they can get. Because guess what? When they go back out in the community, they're just like anyone else, like the rest of you. And it will affect the healthcare and the well-being of everyone in our community. So this idea that jails are like this separate, secret, behind four walls place and that people coming from the jail are different is baloney. They're just like all of us. Believe me, I've worked in the jail a long time. I can tell you there are people just like you in the jail. But there are also people with tremendous health issues, tremendous poverty, mental illness, crippling substance use disorder. Why would we not use this opportunity to give them the best possible care possible? And guess what? That's going to make healthcare throughout our community better. So really, kudos to the state. I do see this as the most transformative thing that's happened in my career. And while I now have another job on top of my other job, I am so grateful and so excited about this because it's finally putting into law what we've been trying to do for so long. So
I have one more. That's great. Thanks for reminding us of how important this is. I have one more question for the panel, then we'll open it up for the audience here. On Sydney's slide, you saw those puzzle pieces, and as we moved to the right, there were the reentry pieces. And so the jail is a moving, dynamic institution. It's a moment in time. So can you comment on what the handoffs are going to be like, and what are you trying to work into on handoffs with community entities, with the managed care plan, providers, et cetera?
I can start on this. So, because I was gonna kind of after you talked, what does this look like for a person? So, if pretend like that puzzle is up there. So, if we're talking about what this looks like for a person and how this impacts a person, their health and their life trajectory. So, think about the very first thing. So, I'll say John. John goes into our local jail, and he's asked, do you have Medi-Cal? If not, would you like to apply? Yes, I would like to apply. So then he's assisted with a Medi-Cal application. That right there is huge, right? Because that means if we do all the steps we've just talked about right, on day of release, it'll switch on, right? And that means he can go to a residential treatment program if there's substance use disorder. He can get access to MAT. He can continue the MAT that was started in jail as soon as he gets out of jail. That means he can go to his local community care clinic and get, seen for his hypertension or diabetes or whatever it is. The community support. So I'll kind of go through it, the different pieces. So what that means in first is he gets his Medi-Cal. The next step is that 90-day pre-release services. That means, and we do somewhat of this in San Diego right now, we do in-reach services, but it's not, you mentioned the scope. The scope is not like what it'll be. This means we're gonna have community-based organizations who ideally are used to serving our JI population, that they're embedded in our communities. They're going to start coming into our local jails, building rapport. I see it as someone holding their hand. Hopefully it's our lead care managers and our community health workers, people with lived experience themselves, coming in, building the rapport, day of release, arranging transportation, hopefully, starting to leverage those community supports under calaim, finding a place to call home, getting all of the whole person care, getting all of the pieces connected. So day of release, someone's arranging transportation. John is taken to, say he needs to go to a behavioral health and get his. Well, let me talk about medications. He's going to leave with 30 days supply of medication. That's not what we're doing 10-day, which is some counties are doing none. So we're lucky we have 10 days. He's going to leave with 30-day supply of medication. If he needs durable medical equipment, he's leaving with that. So then there's that next step, right? He's getting into housing. And then in the community, he's now having a care manager and community health workers that's staying with him, you know, up to 12 months, if not more, on his journey in the community to help make sure, you know, say he goes into residential treatment and then he falls back out. Well, that community health worker is getting him back in. So really that person holding the hand. So, I mean, if done right, that's what it looks like for someone. If we really need to connect all the pieces. There's all the challenges, right? There's the workforce, but if we do it right, it really means that John is supported throughout his entire journey, and hopefully we're preventing him from going back in.
That's great. Anybody else want to add in?
Yeah, I mean, I just want to echo it's scalability, right? We've had connections with our behavioral health department for a long time. You know, what we found really is the biggest challenge and the biggest cause of reluctance from community partners to, you know, say, yes, you have an appointment when you get out, is that our patients weren't showing up. And that's understandable. People, I mean, I have a hard time showing up for my appointments, and, you know, I have my 3 calendars and a husband that reminds me. But, you know, it's what's great is that this is, one, the ECM provider to really help facilitate that, 2, really saying to the county, you have to do this. You have to be there. You have to make an effort to bring that person in. And in San Francisco, we passed a health resolution. The Health Commission passed a resolution saying incarceration is a public health issue. But honestly, I've questioned that. I mean, because it's not, you can't say it's a public health issue when public health isn't actively working to link clients when they walk out the door. Like, that linkage can't just happen before release. And then, you know, oh, they didn't show up. Like, that's not how our healthcare can work anymore. Not primary care. No one can work that way anymore if we really want to improve outcomes. And so the ECM model really is transformative in that way. Biggest concern we have is a lot of our providers that have deep experience in this field, lived experience, they don't want to deal with billing Medi-Cal. They just taking that on, which, as you know from earlier comments, is hard to swallow. And plus, there's a lot of liability that comes along with that. So that's been the biggest challenge. And there's sort of these warehouse ECM providers that I don't want to say they're not great. I just don't know anything about them. And so I'm a little nervous about that. I mean, but our health plans have been great partners. And then every talk I say in San Francisco a lot, so please forgive me for that. But in this case, I'm not saying how we're great. I'm saying where we have challenges, so maybe that's more palatable. But we don't have capacity. We really don't. Like behavioral health, and what do you link someone to in behavioral health? Like residential treatment, and there's only so many beds, and then there's outpatient treatment, but that's not really a program that then is like it doesn't quite operate that way, not to mention the federal restrictions around information sharing for that. So there are some real challenges having to do with the law, having to do with capacity, having to do with the criminal justice system is now going to be like, oh, ECM provider, can you provide a court report to say my client's doing what they're supposed to do? Like, these are all challenges that are going to come up that we're going to have to deal with. So yes, fabulous. Let's get the linkage. Let's get the support. There's a lot that's going to come with that we're going to have to problem solve. So
thanks so much. Now I'd like to turn to the audience. Are there questions?
Hi there. My name's Dr. Manisha Sharma. I'm in San Diego with Lynn Highland. And, I'm a New Yorker. I think you can hear me probably without the mic. There you go. Fair enough. I just want to say that I agree, Tanya, that what you're saying, this is really transformative. Sydney, this question is for you, just because I'm a social medicine, family medicine doc, so I come from like really thinking about the justice system and I really call it the legal system because I don't really find a lot of justice in the legal system, and just really being thoughtful about sort of how we think about these sort of labels, right? But the thing that bothers me, I've been in San Diego for 5 years. I've moved from the East Coast. And one of the things that we have that's really unique that is not like San Francisco is we have a detention center that I live literally 3 miles from the border. And I think a lot about the definition of detention center and who comes through that. And what I don't see is how we're thinking about now that Medi-Cal, irregardless of your immigration status, how are we thinking about those folks? And I'm just curious if DHCS is defining detention center, because there's a lot of confusion around that. And in policy circles, we talk about it saying, no, that's included. But I don't think plans understand that. And I'm just wondering if you could define detention center, because in San Diego, it just looks different. And how are we going to wrap around those folks who actually are scared to be on the grid and also really scared to just be navigated through the system and build trust in that? And I was just wondering if DHCS is answering that.
Yeah, thank you so much for your question, and just for the information about justice versus legal. Personally, I agree, so I appreciate you pointing that out. As far as the detention centers, I will say in order for me to give like the most accurate answer, I'd have to go back to our standard terms and conditions from the federal government, which is like a 500-something page document. So I won't put you all through me researching this, but it is specified there, and I believe it's just detention centers that are run by the county. But again, let me confirm, and I could probably do it maybe after this session with you and just look through the STCs really quickly and see what I want to give you the most accurate definition I can instead of me just like trying to wing it.
If it doesn't do that, I would love because for San Diego,
Yeah.
it's so unique, and I think that needs to be included.
For sure, yeah, I can definitely take a look at that and see. To just give everyone some context, we were limited just by the federal authority that we received for this program. So, unfortunately, some facility types were excluded from our approval. So, like I talked about earlier, like federal prisons, city jails, state mental health hospitals, and things like that. But I will look into the particular definition of detention centers like right after this session for you. Of course.
Other questions? Here, in front? We got you.
You're going to hear it anyways. Hey, folks, Lauren, she, her, a pronoun series. Lynn and Tanya, I'm going to ask you a hard question, which is to look into your crystal ball. There's the New York for you. So enrolling people in services is one thing. Maintaining their ability to access and utilize those services towards health outcomes, and I'd offer recidivism outcomes, is another. I'm curious what you all are doing to get ahead of that, to think about to what end are we enrolling in JI and trying to kind of, I always say in healthcare, we can get real good at answering the revolving door, or we can stop the door from spinning. So I'm curious how you guys are thinking about that, particularly with a focus on health outcomes and recidivism.
Well, I work in the jail, so I don't have to think about that. I'm just kidding. I mean, that's an incredibly profound question. Like, what can we do? And honestly, I don't have a great answer. Like, I think, if you look at what research and data says, there's a lot of talk about addressing criminal risk factors. But, like, is that what healthcare does? Or is that what a law enforcement agency does? And where does that overlap? And am I, as a healthcare provider, going to start thinking about, like, your antisocial relationships and, like, all these things? So I think there are huge questions to answer about that. I don't have a great response, really, and I don't think there's really great information in the literature. And, we don't even have really great options for a lot of our SUD treatment. Like, there's so many unknowns. There's so much lacking. At the end of the day, I think I would come back on relationships, And I do think there's evidence to support that being an important value. But also, as I said earlier, the outreach, the engagement, the meeting the patient where they are, wherever that is, the street, the hospital, the jail, the apartment, wherever. That would be what I would say.
I guess if this is like a matrix question, and how are we measuring success, or what does success, is that kind of where what does success look like, or how are we ensuring access? I think I'll start at the very beginning. I think we've started looking at things, and one thing that I've noticed right away is we've been required to collect data on Medi-Cal enrollment, and I'm surprised at how many people say no thank you. And so that one thing is going to impact, we can't improve outcomes if people don't have access. And so that's really where my head has been since we've started submitting these data reports, is the very beginning is how do we help people, reduce the stigma. I think I heard that yesterday, and talking about the stigma. How to reduce the stigma of what Medi-Cal is. It's health insurance, right? It helps you get access. So how do we do that? And how do we help people understand that you can trust? They're in a jail, and we're saying, hey, sign up for this. How do we help them understand, that it's something that when you get out, you're going to benefit from. It's going to help you access medical, behavioral, all these, social supports now under calaim. So we have what we call our Healthy San Diego Justice Involved Work Group. So we bring together individuals with lived experience, our CBOs, our health plans, our justice partners, our health and human service partners, advocates. We do a monthly meeting, and we've started saying, okay, how do we get the word out in the community? If we can help our community providers just start planting those seeds and help them understand the benefits of Medi-Cal. And then in our local jails, we've had, can we run videos with credible messengers saying, this is what Medi-Cal is, this is why you want Medi-Cal, this is why you want to sign up. So we're starting to do more and more efforts of education on Medi-Cal, but we can't have any outcomes if we don't have people enroll in Medi-Cal. So I want to set that, because I think that that's really important right now. And then we can start looking at, recidivism and, and housing, that's a huge thing too, right? If we are having people that are releasing to the streets, are they going to make it to their appointment? Probably not. So we need to start addressing really those, social drivers of health, and to have the better outcomes.
I just want to comment really quickly on what you said, which everyone had a reaction to. The people are saying they don't want Medi-Cal, or they don't want to enroll. So I don't know at what point San Diego asks people to enroll, but let me just tell you, the vast majority of people that come into jail the first 3 to 7 days, they're withdrawing. They do not want to do anything. And most jails that I know of are asking at the front end. And let me just tell you, they don't want to do anything at that point. And most people get out in 7 days or less. So you are going to see a lot of people saying, I don't want to enroll. And I think we need to be very, very careful at sending a message saying people in jail just don't want to enroll. People in jail don't want services. That's because most people we're asking feel like hell and are detoxing. So we have got to take that into account. And I think it's also one of the things I made sure that we are collecting is, why did they decline? Why? Because just saying they declined tells you nothing. And there has to be a workflow that includes follow-up if the person is still there, which probably they won't be, post-detox. You'll get a different answer.
Other questions from the audience? Go ahead. Yeah.
No question.
Probably
no question.
do need this. Hi, everyone. I'm Hasmeen. I'm with the Children's Partnership, and I just want to know, for the department, what kind of considerations you had with this waiver with relation to youth involved in the justice system, particularly because, youth in the justice system come from so many backgrounds. The people responsible of youth vary, whether they're in the welfare system or otherwise. So I'd love to know that. And then from Lynn and Tanya, what kind of effects you think this will have on youth within the justice system?
Much for your question. So I think probably the biggest piece regarding youth that we took in, that we considered, was that eligibility piece of not making a healthcare need a part of the youth criteria. So anyone in a youth facility, regardless of their healthcare conditions or lack thereof, will qualify for pre-release services. As long as they fit the CHIP eligibility group, which, to be honest, most probably do. So I think that was the biggest thing, is just opening up the eligibility. Aside from that, definitely working with stakeholders. We work really closely with the California Probation Officers of California, County Probation Officers of California. I'm trying not to speak in acronyms, and it is so hard. You just forget what the acronym stands for. But we've worked really closely with them to tackle youth facilities and how we can implement this in programs, like where they go up for release every 6 months and they have to go in front of a judge, and the judge basically says yes or no that they're going to be released. How does calaim JI work in that situation? We've worked with them to develop the short-term model to see in instances where they don't have a release date, what are the operational processes? What do those look like? We're starting now to talk to Transitions Clinic Network, just even broader than youth, but working with them to establish their community advisory board to hear from people with lived experience. I think the last meeting we had was about 3 weeks ago, and there were 2 people on the board who are former youth incarcerated individuals. I think one of them was incarcerated when she was 15. So hearing from her, their stories about, their trauma and how we can kind of incorporate that trauma-informed care in this program was really impactful. So we've definitely been working with stakeholders to develop the policy, and now we're switching to working with our stakeholders, especially for youth, on how, things like they talked about with enrolling in Medi-Cal. What does that look like? Engaging the parents, while their youth is incarcerated. They have to sign off on the application, but yet we want to connect with the actual incarcerated individual. Working with them to figure out marketing. How do we market Medi-Cal to people who might not be willing to accept government services, to people who might not know about government services? So a lot of conversations I think still need to be had with our youth and the stakeholders that primarily work with them. So we're definitely continuing those conversations and starting to try to partner with people who have that expertise.
Lynn or Tanya?
Yeah, I would say we work really closely with our probation department. It looks similar, a little different than our jail process because of the parent-guardian aspect. So when someone comes in, we're verifying if they currently have Medi-Cal. Thankfully, a lot of our youth are coming in with Medi-Cal. For those that don't, our prior process before the mandate was to send an application by mail to the parent or guardian's home, and then if they would fill it out, then send it back, and then on day of release, Medi-Cal is activated. We're trying to do more of a less passive, more hands-on approach now, and so that for visiting, we're still working on who that would be. A reentry officer or someone from the probation department would then be meeting with the parent guardian, explaining the benefits of Medi-Cal, helping them fill out the application and submit it. So we hope that increases the number. So those are some of the it's just a different process. We do now have more youth coming back from DJJ, Department of Juvenile Justice, and that's more of our older youth, and that can be up to 25. And so we do have more of an older population now, and then that would look more like our jail population when they're able to say, yes, I want to apply and apply.
Tanya, do you want to weigh in here?
Our juvenile hall has like 10 kids. It's tiny. We passed a resolution in San Francisco to close juvenile hall. I don't know if that's going to happen or not, but it's very small. We're also, I think, one of the only juvenile halls that isn't run by probation because, frankly, I don't think a place that holds children should be run by a law enforcement agency. But they have been, it's easier to manage with 10 youth, and most of them are there for very serious, they'll probably be there for a long time. But yes, we are rolling out all these services in juvenile hall.
Go for it, Sydney.
Sorry, I just wanted to add one last thing too. We're also working really closely with the Office of Youth and Community Restoration as well at the California Health and Human Services agency level too. So I believe we meet with them monthly, and they also provided feedback on our policy and operations guide as well. And I did want to address the question earlier about detention centers. I had to phone a friend because, reading hundreds of pages of policy documents, you tend to forget stuff. So the detention facilities are just the youth detention facilities, not immigration-focused detention facilities. So it's just the ones that incarcerate youth or detain youth. So I did want to make that clear. I'll probably work on clarifying that on the slide as well, so that's more clear. So thank you. Thank you for your patience.
Well, we've come to the close of the panel. I have two requests, though. One is to do the evaluation here and help ITUP improve our programming at this conference, so we really appreciate your feedback. And the second request is let's give our panel a hand for this great presentation.